about med adherence and the role of loved ones. Yes, I got it recorded. Okay. And infusing some CBT within that, all things for those of us who are non-prescribers to really be considering. And, one thing I'd, like you to think about as we start this or go through this didactic today is, as non-prescribing clinicians, as therapists, what is your role, or what do you see your role as it relates to medication adherence and family members, if any? So if there's some time at the end, we can chat about that. All right. So a couple thoughts about adherence, just in general. Even with the best of intentions, I think that adherence is difficult for most of us. I swear, you have 2 pills a day, inevitably I'll forget them half of the week. It's not because I'm intending to be medication non-adherent. It's just life gets busy, things, take priority. And I think that's a struggle for many of us. And also, really recognizing that the struggle with accepting what's going on with an illness or a diagnosis and accepting care, being open to treatment, including medication, but not limited to that, isn't limited just to the individual with the diagnosis. So this is a journey that families have to go on as well, in their level of acceptance and their level of support of, treatment recommendations. And this is due to lots and lots of things. A few things that a loved one may be struggling with is stigma related to mental health issues, fear about, treatment recommendations, especially medication, think about the potential costs and benefits, having misinformation about diagnosis, treatment, medication, or limited information and understanding. Some individuals don't believe in mental illness, or specifically that their loved one is ill. And there are a lot of valid concerns about medications. So really helping families to think through, where their difficulties with accepting diagnosis or treatment is coming from. And we'll get into that a little bit more. So knowing that there can be some difficulties in, loved ones, how they're feeling about potential for medication use, they can really have an impact on an individual's level of adherence. So typically loved ones will fall on a continuum when it comes to med adherence. So they're either all in, medication is the answer, it's the magical pill. They're all out, no way, I don't want my loved one on that poison. They're kind of in, but I'm nervous about it. Or I'm unsure and I don't think so, but I'm open to hearing a little bit more about it. And so it's really helping them think through, what is it that's keeping you a little bit in? What is it that's keeping your one foot out the door? And that's the space where we can do a lot of work. Importantly, for across the treatment team, not just limited to therapists, but it's really talking about expectations of medication, treatment, all of that. Early on, very, very early on in treatment, and often. So revisiting these discussions, they're not one-time discussions. All right. So loved ones' difficulty accepting a diagnosis or treatment or medication can lead to difficulties with treatment adherence or supporting the treatment plan. And they have a very strong impact, especially when the individual resides in their home, right? So if they are in disagreement with the treatment recommendations or with somebody being on medication, that can have a very powerful impact on what the client chooses to do. Difficulties with accepting treatment recommendation can lead to discord with the individual, with the treatment team, with other family members, especially you see this if there are differing opinions within the family. So if you feel like, mom is all for any and all treatments and dad is against any and all treatments, that can create a lot of conflict. And it can lead to a lot of increased stress, frustration, grief, you name it, for the loved ones themselves. So families are going to be involved though. Typically, we will be able to catch them at medication appointments, right? So some may be a little uncertain about what their role looks like as part of the treatment team, and the family, loved ones truly should be a part of the treatment team. It should be regular practice. We should approach everything from a systems perspective. You'll hear me say that a lot. But typically, if families are sort of on the fence or, still figuring out what their role is, the medication appointments are where they're going to show up. And so things that we can do as non-prescribing clinicians are helping them get ready for those appointments. And we'll talk about that in more detail in a couple minutes. Ensuring the loved ones know that they're a part of this treatment team. And this can really decrease frustration for everybody involved. So not just the individual, not just the family, but also for us as team members, also for the prescribers. If we're all sort of on the same page, working towards the same goal, we know where everybody stands. It can be a very, very helpful by lifting off some of the anxieties around it and some of the difficulties and the tensions that can, float into our work. And so how do we really support loved ones as they're supporting the individual's treatment adherence, including medication? So first things first, the most important thing that you can do, obviously this is after you're working with the individual and you've come to an agreement that yes, I'm the identified client and I do want my loved ones involved. So after that stage, when we're all on that page, which we've talked about that in previous, engagement with family talks, but it's really about understanding the loved one's perspective on illness and treatment recommendations. If we don't have this information, any recommendations that we're making could really undermine the work that we're trying to do. If we're making recommendations that are in misalignment with a family's belief system, it can feel very insulting. It can feel like a personal attack. It can feel very dismissive as a loved one. And it's important to get that information from the source. The client may say, mom's all for anything or dad's all against everything. But it's important to really talk with the families. One, it's a sign of, respect. It really helps to build rapport, but it also gives them the space to share their questions, their hesitations, their concerns. Inviting them to the initial intake appointment. So, when calls are made to get those scheduled, it's who will be joining you at your intake appointment rather than, you can bring somebody if you want. Those are two very different messaging. So we want to incorporate families from the very beginning to get part of the history, to get other person's perspective, get all that collateral information. And a lot of folks have been, with us in treatment for a while. And so it's sort of not hitting a reset button, but easing our way into these conversations about involving loved ones, about loved ones thinking about medication, what their concerns are. So when you've had somebody a bit longer, sometimes we have to approach it differently than somebody who's new to our caseload. So really hearing concerns of loved ones without judgment and without trying to push our own agenda, which is, we want you to follow the recommendations of the prescriber and the rest of the treatment team. Sometimes we have to be able to let that go for a little bit and do some of that background work, behind the scenes work, that genuine curiosity, information gathering, like we talked about with LEAP and anosognosia, same kind of an approach. So really trying to learn about, for the loved ones, where do these concerns come from? Did they have another loved one, a parent, a brother that they watched, that lived with a mental health diagnosis who really struggled. And so they're afraid to say that, yes, my son also has schizophrenia and I saw my brother go through that for years and years and years. What's perpetuating the anxieties? So is it something that they're seeing on the media? Well, my loved one couldn't have schizophrenia because he wouldn't shoot up a school. I've heard that. So, what is it that's keeping the anxieties going? What evidence do they have that supports the concerns? Is it something that has happened to them directly? Is it something that happened to their neighbor's son that they remember very vividly? Finding out what their biggest fear is, what the diagnostic label means to them. If they hear the word schizophrenia or they hear antipsychotics, does that mean, game over, there's no growth potential, this person won't be able to recover, this is going to be something chronic? So really finding out what they're identifying with the labels that we're attaching to things. Do they feel that medication is the only answer, or opposite of that, do they absolutely not want somebody on medication because they're so fearful of it? So really diving in with them related to these questions. Then, really thinking about our language choices and being careful about that. Just one example is, a psychotic break. Break implies something that's broken, oftentimes not fixable, but a perception problem, when it's described in that way, leaves some wiggle room for some work to be done. Something that can be addressed by both medications and evidence-based psychotherapies. We want to build rapport with families, get their questions answered. Nothing feels better to a family who, calls in and has a question and they get a response quickly. You have probably faster access to a nurse or to the prescriber than a family would, and waiting for a call back. So if there's an immediate concern or something that's been on their mind and you can get that question answered for them, that goes a long way with really solidifying a relationship with a family, because they feel heard and they feel that they're being supported. And then working as a team, that's very, very important, no matter what setting you're in, community mental health agency, hospital, really working as a team and utilizing the skills of other members of your team. Case managers have this beautiful skill set of being able to go out into the community. They have access to the families. They have relationships with these individuals. They can get a lot of insider information. Prescribers looking to them for facts and figures related to medication. So, it's outside of our scope as non-prescribing clinicians to get into the nitty gritty of this medication could cause this side effect, but we can share information. We can connect them with the people who know that information. So really, really thinking not only a systems approach, but a team approach. So when we're thinking about, you've established this rapport, you have a good understanding of what's going on from the loved one's perspective, what their concerns are. And then it's really trying out some of these techniques that we're going to talk about for the next couple of slides, but helping them prepare for medication appointments. I think it can be very frustrating from a prescriber's perspective, because I hear this a lot, that family comes in and they monopolize the whole appointment. I don't get any one-on-one time with the individual. And it's very, very frustrating. And that can create some tension. That can mean, we can't have the family come back to the appointments because I need to see the individual to talk about their experience. But if you can help a family sort of be concise and clear with their questions, with their concerns, get some questions answered before they go in, have a few bullet points, role play with them about how the session may go, that's a really powerful tool. And it's a really efficient and effective use of time. And that helps to build relationships across members of the treatment team with individuals. Even things like, why is my loved one taking this medication? How long before I see if it works? What if it doesn't work? What's plan B? What are the expectations? What are the side effects? What could I look for to tell me as a loved one that he may have stopped taking the medication? All of these questions, you can help them streamline that. And then keeping track of medication. So I'm not going to go into a lot of detail on this one, but you all will receive the email and also some various attachments. But they're, tracking quantitative data is a very powerful tool, especially when you gather that from multiple sources. So, as practitioners, there's the clinician rated dimensions of psychosis symptom severity that you all have access to. It's a wonderful measure. But, it might be a little bit difficult for families to track. So is there a simplified way to do that if you just want to be tracking, symptoms, delusions, hallucinations, depressive symptoms? Or you can opt for a more basic tracking sheet, a 10-point scale that people are looking at over time, and everybody is finding this information. So if you have an individual, potentially multiple loved ones, we track as providers, the prescriber or the nurse can be able to kind of document what they're seeing. And you really have a powerful data set when you pull that together, and then you're looking at it over time. You all are familiar with dialogue and the recovery assessment scale, the RASD. And so thinking about, are there domains that family members or loved ones could assist with tracking? Is there a way that on that the RASDS potentially where they can fill in the comment section of their observations and kind of do that alongside the work with what the loved one's doing? Are there measures out there that really look at positives? So we don't always just want to be tracking symptoms. We want to be tracking other life events, medication adherence, things like that, but also importantly, positive dimensions. So, one of the goals is to get up and shower every day. How often is that occurring? Engaging in pleasurable activities. How often is that occurring? And if any of you know or use a really great scale for looking at those positive dimensions, we'd love to hear that after the talk, because I think that would be really useful information to share. So tracking, very, very important. Here's that clinician dimensions of psychosis severity scale that's free from the American Psychiatric Association. But again, if they're concerned about medication and somebody starts a new medication, it's nice to have a baseline. And then once medication starts and you track for the 8 weeks or whatever, and then if there's a medication change, it really, it can tell a story. This data can really tell us a story about what's going on with the individual. So it's an important thing that we don't do often enough, I don't think. So once loved ones are even open to discussing the idea of medication, other things that can be done, behavioral experiments. So, are they willing to decrease their use of marijuana or stop it altogether for a set period of time while they're tracking symptoms? Are they willing to go out for a walk every day for a set period of time while they're tracking symptoms, whatever it might be. Looking at risk benefit analysis, shared decision making is very important. Thinking of pro-con lists is very important. And I also will send you, or you will send, the Ottawa Personal Decision Guide is this really amazing tool. So when we think of a pro-con list, it's usually just that. Pros of taking medication, cons of medication, but there's a flip side to that. So it really should be thought of in 4 quadrants. Pros and cons of taking medication, pros and cons of not taking medication. Surprisingly, you'll get a lot of different information, but having an individual complete this, having loved ones part of the discussion to make really an informed choice. That this is a really wonderful discussion starter or discussion tool where it helps somebody rank what's most important to them based on the decision and the outcome. What are the potential outcomes of making each of the choices? What is most important to them? So it's a wonderful tool. I would highly recommend it. And it's a great one when people are sort of ambivalent or on the fence about taking medication or being supportive of someone taking medication. Provide accurate information to loved ones. So we said that there's a lot of misinformation or lack of information, but always asking for permission. It's important to have rapport with that loved one first before just diving in and saying, no, that's incorrect. Here's the facts and figures about that medication. But really asking for their permission before you share your perspective. So I heard that you mentioned X. I'm wondering if you would be okay if I give you my thoughts about that, and then we can check in with the prescriber. That's a much different approach, and it opens people up a bit to hearing your perspective. Preparing a safety plan, a safety net approach so that everybody feels comfortable that, okay, if we agree to test out this medication, what are things that I can look for? What if something bad happens overnight or on a weekend? Who can I call? What are, really helping them map out a plan. So that way, if something does go awry, they feel like they have support in that, even if it's after hours. The CBT strategy is really just helping families like you would do with a client. What are all the possible outcomes of taking medication? What's the scariest one? How likely do you think that is to occur? And how anxious does that make you? Then you kind of talk with them about the evidence for and against each of their concerns, reach out to, prescribers, get information, and then have them sort of relook at their list, reevaluate it. So now, how likely do you think it is that scariest thing? And how anxious does that make you? What about all these other potential outcomes that could be happening? And typically what you'll see is anxiety levels are down and they're not so convinced that the scariest outcome is going to be the outcome. So it's a great way to have conversations when it's families' anxieties that are kind of inhibiting the use of medication. And then you talk about the benefits and the potential risks, and then again, come up with a plan to make sure everybody's comfortable. Sometimes if there's tension with a family, your role becomes supporting that family and how to support their loved one and living a really happy, healthy, fulfilling life. And so maybe it's moratorium on talking about medication. So your space becomes the medication-free zone for a set amount of time. So for the next 3 sessions, we're not going to talk about medications in here. We're just going to talk about how is your loved one doing? Are they living their happiest life? If not, let's talk about things that we could do. And it doesn't have to always involve medication discussions. All right. So just very briefly, helpful for loved ones to know, validating and normalizing concerns that all medications have risks and side effects, even your Tylenol and your aspirin. But there are ways that these can be mitigated that you can talk with the prescriber about. Medications really are intended to be used at the lowest effective dose, and they should be helpful in recovery. And if they're not, that's a discussion to have with the prescriber. Really reinforcing the biopsychosocial model so that they understand that they are, 1/3 of the picture, and medications potentially could be a third. And then the work that you do with them in individual work is very, very important, also a third. But actually drawing this Venn diagram and helping them understand, how all of these 3 have to converge for an individual to be healthy. Helping families understand, the language they're using. Did you take your meds today? Every time somebody's having an emotional response or reaction, what does that mean to that person? Why can that be detrimental to their relationship? And giving them new language. Providing encouraging feedback to the individual. So, you don't have to necessarily say, wow, since you started your medication, I've seen you come out of your room a lot. It's, over the past couple of weeks, I'm so thankful that you've been coming out to the kitchen with me more, things like that. All right. And helping families be able to express when they have limitations and what they're comfortable with. We want to be careful about making families medication monitors, because that doesn't work for every family. And sometimes that can really put families in an uncomfortable dual role, sometimes unsafe situations. So we really have to make sure it's appropriate when we're making those requests. So on here, there's a couple, potentially sticky situations. If you have a family or a client, it happens a lot. I'm not getting any better. I need a med change. And when we're guilty of doing this too, and then it falls on the prescriber, what do we do in those situations? What are other things that can happen other than kind of putting us in the middle? How do we help facilitate those discussions? So you can see those in your PowerPoint. But there's lots of sticky situations when it comes to medication adherence. Adding in the family can sometimes gum up the works even more, but it's important conversations and it's important to be having with them. And so hopefully, things that you'll consider addressing in your work. So that's it.